So part 3 would be submandibular and sublingual gland lesion. Submandibular space and sublingual space is in the oral cavity in a full mouth. So when you find axial images that include body of the mandible, you'll find the important muscle. It's called the mylohyoid muscle. This is kind of running along the medial border of the mandible, and this demarcates the submandibular space to sublingual space. As I showed you earlier, the sublingual space is above the mylohyoid muscle. In the coronal view, notice the mylohyoid is kind of flinging the full mouth, kind of supporting the full mouth, and sublingual space is above this sling. But as opposed to submandibular spaces below the mylohyoid line. Notice that the posterior border of mylohyoid muscle has an opening. So through this opening, submandibular space and the sublingual space communicate. So that's the important thing, that the lesion can spread from one space to the other space through this opening posterior to the mylohyoid muscle. Sublingual space contains, of course, sublingual gland and the nerve and then vessel, but its submandibular duct is opening in the sublingual space. That's also important things to keep in mind. Again, this is the schematic diagram of a mylohyoid muscle and also sublingual space, as opposed to submandibular space is posterior and inferior to the sublingual space. And an opening of the mylohyoid muscle, again, allows these two spaces to communicate each other. This is an example of infection, an abscess. And notice there's a fluidal collection, a remain-enhancing fluidal collection in the floor of the mouth. And when you're looking at the bone density, you notice there's a bone dehiscence. And the patient presents with jaw pain and swelling. So this is clearly suspicious for infection and abscess formation. And oftentimes when you see something like that along the oral cavity or mandible, you look for bad teeth. And here the bone window images, notice there's a big apical lucency with bony erosion in the lingual surface of the mandible that most likely causing this odontogenic abscess. Another case of dental abscess, notice there's a focal area of the fluidal collection and abscess formation with the focal bone destruction. And this is the case of submandibular space abscess from dental infection. Submandibular gland, it could get really angry and big like this. Notice there's a normal submandibular gland on the right side, and left side is like twice larger than the contralateral side. When you see the enlarged submandibular gland, you have to think about two things. It could be stone, it could be cancer that are obstructing submandibular duct. As I said, submandibular duct open into the sublingual space, which is in the small mouth. You really need to look far anterior to see what's going on in the full mouth, and notice focal area of large stone obstructing submandibular duct. So this is the myelolithiasis with submandibular gland infection. When you see submandibular gland mass lesion, the clinician does not know if this is the submandibular gland primary tumor versus lymph nodes around the submandibular gland. Again, submandibular glands develop much later in a gestational age, so they don't have a gland in a lymph node inside a gland. The lymph node is outside of submandibular gland, as you can see on this case. These are submandibular gland lymph nodes. As compared to the cases here is within the gland, there's the intrinsic mass within the submandibular gland. So this is important for us to tell surgeon or clinician, because when you feel the neck mass, they cannot tell that it's submandibular gland lymph node or intrinsic submandibular gland mass. So this is a case of submandibular gland lymph node and one bead zone, as compared to this is a benign mixed tumor in the submandibular gland. When you see the mass region in the submandibular in the infant, again, think about hemangioma. This is a very common finding, particularly when you see multiple flavoids in the calcification. And this is a submandibular gland hemangioma with contralateral hemangioma involvement. It is still not quite a muscle to muscle. So in terms of differential diagnosis, primary neoplasm of submandibular gland lesion included pleomorphic adenoma or BMT, adenocystic carcinoma, mucoepidermoidal carcinoma, adenocarcinoma, and an infant or young child will think about hemangioma. So the differential is similar to parotid gland, except to remember 50% of submandibular gland tumor is malignant. So the odds of malignant tumor is much higher in the submandibular gland as compared to parotid gland. You could have a metastasis to the submandibular lymph node, which is outside of the gland. You could get Wharton duct obstruction from pyelolithiasis, more common than the parotid gland stone. And also tumor in the floor of mouth also causes the enlargement of submandibular gland, or infection of the gland itself, or styloadenitis from ascending infection from oral cavity. So moving on to sublingual space. The sublingual space is medial to the mylohyoid muscle, and including sublingual gland and also submandibular duct and also neurovascular bundle. Mylohyoid muscle, really key muscle sling, as I said, separating submandibular space to sublingual space. But it does communicate along the posterior margin, as I said. And important concept is the sublingual space is like a horseshoe shape along the mandible. So it does not go inferior to the mandible as compared to the submandibular space. It's more perpendicular to the sublingual space. So here's an example of sublingual space benign mixed tumor, well-defined enhancing, homogeneously enhancing mass in the sublingual space consistent with benign mixed tumor. Other cases, this is sublingual space abscess, similar to submandibular space abscess that I show you, and oftentimes those are associated with a dental infection. One thing that's commonly seen in a sublingual space is ranula, and notice this that this cystic lesion is above the mylohyoid muscle, so you know the lesion is in the sublingual, not a submandibular space. So coronal images may be helpful if you have a doubt whether that was above or below the mylohyoid muscle. And so in terms of space, this is a sublingual space and a fluidal density, so most likely ranula, and more than the epidermoid. Another case of a ranula in the sublingual space, the fluidal collection, again, in the sublingual space, just abutting on the genioglossus muscle. And again, submandibular space is more posterior and inferior. Sometimes you see more commonly squamous cell carcinoma of adjacent oral cavity or floor of mouth directly embedding to the sublingual space. So this is an example of floor of mouth squamous cell carcinoma, but that's embedded into sublingual space, which is right here. And then this is much more commonly seen than the primary sublingual space tumor. This patient came in as a history of right neck mass, and we did not find the neck mass on the right, but what we found is submandibular gland is absent on the left side. When you're looking at the sublingual space, it's a kind of like a homogeneous hyperdense masses, looks almost like a normal density with submandibular gland. So this is ectopic submandibular gland in the sublingual space. It's almost like a duct never formed, so the submandibular gland is in the sublingual space. So this wasn't abnormal mass, but rather normal glandular tissue in the sublingual space. Back to one more case. This is the case of epidermoid in the floor of mouth. Again, another differential diagnosis when you see cystic mass lesion in the floor of mouth. Imaging findings, the more sharply marginated region, and then fluid density. Sometimes you see the multiple cystic components, and this is the case of delmoid epidermoid complex in the fourth mouth. So to summarize, the sublingual space differential diagnosis, much more common found lesions of stone or stenosis, the submandibular gland duct, abscess, very common in a dental abscess or oral odontogenic infection, and also oral cavity squamous cell carcinoma embedding into the sublingual space is much more common than sublingual space primary cancer. Less commonly seen in a ranula or epidermoid or delmoid and a benign next tumor. And occasionally you may see sublingual gland carcinoma or phylloceal. So in summary, understanding anatomy of spaces containing salivary glands such as parotid space, submandibular space, sublingual space is essential for accurate differential diagnosis. Remember, facial nerve is running in the parotid gland, which is important anatomical landmark for surgical resection and also treatment planning. Auriculotemporal nerve, when you go running behind the mandible, that could be the source or pathway of perineural spread. So you always need to pay attention to auriculotemporal nerve as well as stylomastoidal foramen where the facial nerve is exiting. Keep in mind that the parotid gland contains the lymph nodes because of the early development in the gestational age. So the lymph node metastasis from face and scalp goes to intraparotid lymph nodes as compared to submandibular gland lymph nodes are outside of the gland. Anatomical landmark for the sublingual space and submandibular space is mylohyoid muscle. So again, coronal images may be very important to look for where the lesion is located. And that's the end of the third part.